joining us today is Annette Hicks. Annette, you've got quite a global role from what I've been hearing. Can you tell me a bit more about your background?
I've got a clinical background, a nurse, trained as a nurse originally, specialised in infectious diseases actually, and I did operating room nursing and was an administrator for a period. Got a little bit bored with that and entered the ICT industry, and I didn't really realise what it would end up, where I would end up.
Yeah.
So now my role is the Senior Health Advisor for the Chief Medical Officer at Watson Health, and it's very interesting what we're doing today in ICT.
It sounds like you get quite a few opportunities of travel. And
I do, yes. I spend a lot of time working with other hospitals in other regions. I've spent most of my time in Asia Pacific, so and it's really interesting, really interesting.
Now tell me about what's brought you here today. Like you've got something pretty exciting to talk about.
Yes,
so.
I was going to talk about Watson and Watson for Oncology, Genomics Advisor and Clinical Trials Matching. So that's our artificial intelligence.
3 parts, isn't it? 3 parts to Watson.
Yeah.
Okay. All right. Let's start with part number 1 then.
Watson for Oncology. So just to sort of backtrack a little bit so that people realise, IBM invented Watson, which is a cognitive computing, about 2011. Interesting enough, the first industry that came to us was healthcare.
Okay.
And it was actually Memorial Sloan Kettering Cancer Centre, who's a specialist oncology in the US, and they thought that Watson would be really very pivotal in their institution. So with them we built Watson for Oncology, which is an advisor to clinicians, oncologists, on treatment options. And it is built around a large corpus of knowledge on clinical details about protocols, published papers, a lot of information about how cancers have been treated, and that then becomes what we call the corpus. And then we train it with clinicians who run cases through it to make sure that what recommendations are coming forward would meet the appropriate guidelines and are refined enough to actually meet the needs of oncologists. So it is by putting the attributes of a patient against those corpus, it comes forward with recommendations in a ranked way. So it ranks them against like a green option, which is the most appropriate, a yellow option, which is they're potentially okay, but there might be some caveats in there, and lastly red, which you shouldn't really be recommending at all.
Okay. So it kind of helps you make a decision, really, doesn't it?
Yes, yes, that's right. And it enables the clinician to actually then track back into the system and look at all the evidence that actually supported that recommendation, and what were the attributes that were actually key to that.
Okay, and in the second part, were you talking about genome? Is that,
Yes. Yeah. So we've got a Watson Genomics Advisor, which is actually, and it sort of came off the back of the oncology stuff we were doing at MSK, but it actually was with the New York Genome Centre. We were doing work with their sequencing using high-performing computing, and they had seen the work we were doing at MSK, and they thought that the genomic work would be well aided by a Watson type capability. So what it's doing is actually taking the sequence data and actually analysing that data, looking at what the driver mutations are for that cancer, and then coming forward with the appropriate drug therapies that would target that mutation. So it's really stepping into that precision medicine space, which it's more of an adjunct to the clinician, because normally that would have taken a lot of hours to do that analysis. It's done in a much shorter period of time. So it makes it scalable. And we know that genomics is going to be one of the drivers in oncology in the future.
And this is pretty high-tech stuff we're talking about, isn't it?
Yes.
This is essentially taking someone's DNA, essentially, and then working out what's wrong with them, and then putting it through a computer-based program that can help analyse.
Because, genomics is very data-rich, and the challenge is that previously it's taken a lot of human manual time and compute time to actually do that analysis. What we want to do is make it available to the clinician, because as we have been implementing in Genomics Advisor, we found that a lot of them are looking at saying, well, not only do we want it to enable us to do that analysis, we want it to be able to store our data on the genomes that we have found that impact cancer, so we can use them in our analysis. So it's sort of interesting what they want to use it for.
I'm very interested to see what's going to happen in about 10 years' time when you've got this insanely amount of data. Like, where can we go with this, and what can we develop?
And I think that's the thing that is very exciting. It's and I gave a presentation yesterday, but it's really scaling some parts of human capability so that we can actually do the stuff that we know best.
Yeah. And your third part was clinical trials?
Trials matching.
Yeah.
Yes, it came with the Watson for Oncology, because often in oncology the only option a patient might have is a clinical trial.
Yeah.
And only 3% of people get access to clinical trials, and that's a global data. And what we have done is use the capability of analysis of large data and alignment to criteria, so we can actually take a patient criteria and match it against trials that are actually appropriate for that patient. And often we can rank those as well. They get ranked as in fully compliant, so they can actually go onto that trial, it's green, or yellow, where they might have some attributes that don't meet the requirements of the trial. And then the clinician can have a look at that and decide and make an assessment whether there's any way that they would be able to change some of those criteria that would meet the trial, depending on what the client wants. So and really the ambition here is to increase the number of people who have access to the appropriate clinical trials, because most oncologists would tell you that clinical trials sometimes give you the best outcomes for your oncology patient.
Very exciting.
Yes.
Yes. So where has this been implemented?
So the Watson for Oncology, and we're very, I think we're very lucky in this region. We've got, in the Asia Pacific region, we've got the largest number of implementations outside of the US, and that's in India, in Manipal, which is a private hospital. They've got 7 sites that they're actually using Watson for Oncology. Bumrungrad in Thailand. We've also Gil Medical Centre in Korea, and that's for Watson for Oncology. And for Genomics Advisor, we have a research version we're using at Tokyo University, or the University of Tokyo. So, and we're pretty well represented within our portfolio and have a lot of experience with that.
With you being here today, am I hoping to see something here in New Zealand?
Yeah, we are talking to one site. We've talked to a number of sites, and really, I think one district health board has said yes, they actually want to actually do it, and they're talking to us about how that might happen. So,
cool. Really cool.
yeah, so once one site, because the system here in New Zealand and the system in Australia are fairly similar, they're very, they're public health. And there's very unified in the way they look at solutions, and Watson for Oncology would be something that if one of the DHBs did take it up, the rest could then look to access it over time.
Yeah, and see how that works. And
see how it works. So it's a good opportunity.
Okay. And so I'm excited to see about the future. So where is this all heading?
And I'm excited as well, because I think that the real future, we're now working about giving Watson eyes. So a lot of the work we've done to develop the Watson for Oncology and Genomics Advisor and CTM has been around text-based, structured and unstructured text. The ability to now look at images and do analysis and then bring together the text information and your image information to make provisional diagnosis or to make recommendations would be the next step, and we're working on that already here in this region.
So this is Watson Eyes, like radiology?
Yes, we're looking. Yeah, we're looking at radiology. So we're looking at you know, any radiology modality. So we look at anything. So, but we're doing retinopathy type stuff, and we're also looking at melanoma, doing images.
Right.
So it's. But a lot of people are doing the same thing, but what we're trying to do here is to take that image data and actually marry it with clinical text data to give you a better idea.
I'm going to ask the elephant question in the room that everyone's probably wanting to know. You must get a lot of challenges with clinicians. I mean, if you are going to implement something called Watson Eyes, will that mean there's a radiologist job or a dermatologist job?
And I think that we get it with Watson for Oncology. Genomics Advisor not so much, but Watson for Oncology. Yes, we get it all the time. I get clinicians saying, I don't need that sort of support, I'm actually expert. And most clinicians that we talk to are experts in their field, so they're quite correct. But I think it's all about scaling their capability to actually do more and do the things that they're good at, which is difficult diagnosis and treatment dilemmas,
Yeah.
whereas Watson supports that by giving them the information. And I've found that many clinicians really do like that once they start using it. So I think when you first introduce them to the topic, they become quite threatened, and then once they start using the tool, which we've got this experience in this region, they really love it because it actually gives them more time to do what they should be doing.
Yeah, which ideally is the communication part with the patients.
And there's a lot of work in communicating. And some, we're trying to look at whether we can involve patients in some of the decisions about their treatment by giving the clinician that ability to actually show them some information. So we've even, in some of our versions, looked at putting patient-like information about the treatment protocols so that they actually are aware of what will happen and what they need to be looking out for.
Yeah. That's really important because I guess with every disease process, although we have a uniform understanding of disease processes, it does present differently in each person.
That's exactly right. And it also, from what I can understand from the oncologists, is if the patient is actually on board and actually participating, you have a better chance of getting adherence and better outcomes. So that's what they're trying to get.
Yeah, it's going to be a big challenge, especially with health literacy and all those
That's
kinds
right.
of things.
And which is why we've had to write those patient information in a very different form to what it's already in Watson today for clinicians, because we speak a different language.
And it's been really great talking to you. I'd love to carry on, but we have to cut it short now. So.
It's very good talking to you too. Thank you very much.
Yeah, enjoy the conference.
I will.
Okay, thanks.
Thank you.